Welcome to Clinical Problem Solvers, virtual morning report. I'm Steph. I'm excited to be here with you today. Zavin, who's usually with me, is in the hospital taking care of patients on his own, so he's not able to join today. He looks forward to joining next week. And happy September 1st to everyone. Suddenly, we're in the 9th month of 2021. I can't believe it. For those of you that are applying to residency in the US right now, good luck finishing up all your application materials. I know all the programs are really excited to get to review them and meet everyone. I know it's a busy time of year, so good luck to all of you doing that process. And we will look forward to hearing a case from someone and hearing which two of you would like to chat through it with me. In the meantime, I will just share some reflections on yesterday's neurology virtual morning report, which was just outstanding as always. I feel less neurophobic every time I listen to one, which I know is entirely the point. So just really appreciate that as part of our clinical problem solvers curriculum. Doug, who many of you have seen present a case before, who's a neurology resident at UCSF, shared a case of a gentleman, a 62-year-old gentleman with gait disturbance. And I have just three major reflections for you. One is, as always, Aaron and the discussants just did a fantastic job right off the bat, dissecting a schema just to the chief concern. Really laying the groundwork for all possible diagnoses by sharing their thinking with just the main symptom. And, they very nicely reviewed really how complex walking is. I have two young kids, a 5-month-old and a 21-month-old, and seeing them learn to move and walk, I think it really reminds you how difficult it is for your body and your nervous system to actually learn how to do it when you see that it takes, about a year to figure out. But the group really reviewed that, having a normal gait really requires many systems to be intact. Your sensory system, from what you see, to what you sense with proprioception, to your sense of balance with your vestibular system has to be there. You have to be able to kind of coordinate that input in your cerebellum and cortex. And then you need to have appropriate outputs on your motor pathways and the right strength in order to execute the gait. Not to mention, in the meantime, your rest of your body has to be working well. Your joints have to be intact and not painful. You have to have adequate, blood perfusion to your brain so you don't get dizzy. So it's really quite a complex process. And they laid out just sort of the sensory coordination, motor pathways for us very nicely from the beginning. The case evolved to really define for the 62-year-old gentleman who had been a veteran in the United States Marines, really had chronic several years of neuropathic pain and falls, as well as some sphincter issues. He had had bouts of urine, as well as a single episode of fecal incontinence, and really just developed worsening falls over years for which he was evaluated. He had a background of some substance use disorder, hepatitis C, that played into the differential diagnosis, with the group really kind of identifying early on that there was likely a peripheral neuropathy component, but potentially, given some of the issues with sphincter output, a spinal cord component as well. So they really localized quickly to peripheral nervous system and spinal cord. The second kind of reflection I had is just the beautiful implicit teaching Doug did through sharing his exam. Specifically, he was very methodical in the motor exam, sort of isolating the specific muscle groups, which implicitly reminded us of what innervates those areas when he went through the upper and lower extremity strength. And then when he described the sensory exam, what I liked was just his pure honesty, saying there was no particular pattern. This gentleman had kind of dullness to pinprick on both of his feet, but then he described it as very patchy on the legs. It wasn't dermatomal. It didn't fit any distribution. He was just very frank and honest about it being present in some places, absent in others. And I just like that fidelity to real life findings, which don't always fit a typical pattern that we learn. Ultimately, the group continued to worry about both a peripheral neuropathy, but also really started to focus on the spinal cord, given some upper motor neuron signs on the exam, some hyperreflexia, some increased spasticity. And then ultimately, the diagnosis came when he had imaging negative with a normal MRI of the spine and brain, but signs of inflammation around the spinal cord based on a CSF that had an elevated total protein and IgG and oligoclonal bands. The ultimate diagnosis ended up being hinging on a positive HTLV antibody. And the sort of third teaching point for that I thought was really helpful was when Doug talked to an expert at his institution on this. We often think of, and we've had cases where geography plays into a risk factor for that particular chronic infection. And this gentleman had work in the areas, certain areas in Asia. But then a teaching point for me was that there's some association between a history of IV substance use and HTLV also. So really tying in his social history, both in terms of his work, his travel, his prior medical history of substance use disorder really played into kind of this diagnosis. The final pattern being consistent with an HTLV myelopathy to explain this chronic myelopathic process with some signs of peripheral neuropathy sort of separately also. Really awesome case, fantastic discussion, both in the teaching and the way the case was shared. So if you guys aren't regularly able to tune in on Tuesday, the recordings are just there. They're amazing. Really appreciate getting a chance to learn from those. All right. Franco's got a case. Fantastic. Thanks, Franco. Can't wait to hear it. And just looking forward to seeing if we have any discussants. Anybody ready to yet? Let's see here. All right. Oh, I love Nalayan. Yeah, we're used to the Franco Nalayan dual group every Wednesday. Would love to have you, Nalayan. Anyone else that's interested, just let us know and we'll kick things off when we've got two people to discuss. Franco, while we're waiting, do you want to just unmute yourself, say hi, and introduce yourself to those who haven't met you yet?
Great. Hi, everybody. I'm Franco. I am a Peruvian MD actually, I'm from Cusco. Right now, I'm from Lima. Cusco, for is the place where Machu Picchu is. So many of you can relate for that. And I'm glad here to present the case. So everyone, please join to discuss Nalayan. Nalayan is a great discussant to be there. Hope you enjoy the case.
All right. Thanks, Franco. Can't wait. And looks like Samuel or Samuel would like to discuss also. Do you want to say hi and introduce yourself to everyone?
Oh, hi, I am Samuel. I am a last year medical student in Mexico. And I am from Colombia, but I've been studying all my medical career in Mexico. So that's what I know for. And welcome. I would love to discuss with you guys. It's my first time, so I will be a little nervous, but I'm looking forward to it.
Thank you for volunteering. You'll see it's a very friendly, comfortable space. I think you'll really enjoy it. Thanks for being here. And Anna, awesome. Someone else who's new here. Do you want to say hi and introduce yourself?
Hi, everyone. So I've been here like maybe 3 times, but I'm actually officially here today for the first time. And I am a 4th year medical student in Brazil. And yeah, I think this is it. I love reading. I love climbing, doing outdoor sports, and I'm very excited.
You said you enjoy climbing, Anna?
Yeah.
What kind of, like rock climbing outdoors or in a gym?
Yeah, both. Like I've climbed in a rock for the first time like last week, and it was awesome. And the region where I live, we have lots of rocks, and climbing is a very known sport here. So it's very easy if you want to climb a rock. It's very nice. I really enjoy it.
That's awesome. Really, it's so nice to just have something that lets you just take a break from your studies and get out there and be active. Thanks for being here. All right, so we'll get started. So Samuel and Ana, what we'll do is, since it's the three of us today, what we'll do is we'll have Franco share segments of the case. And then Franco, if even just the chief concern is enough for us to just start some discussion, we can even just hear the chief concern and then get into the history of present illness. And what we'll do is we'll have each of you give some thoughts for each section of the case, but you can take turns going first, and then I'll add any additional comments after each of you get to say something for each part of the case. Does that sound okay? All right, so Franco, if you think the chief concern's enough for us to just get some discussion going, we'd love to start that way.
Yeah, absolutely. Actually, I already planned the case in that way. So the chief concern is fever plus abdominal pain.
Okay. Fever and abdominal pain. So Samuel, if you want to start, share your thoughts on how those symptoms build your thinking.
Okay, well, the first thing that I think when I think about fever is about inflammation. So it could be either chronic or acute. And the abdominal pain, well, that also could be a chronic or acute. So it would be helpful to see the timing. And also if there is a distribution of the abdominal pain, because it would make you think about any specific organ of if it is generalized. So it's pretty important to think about that. Also, it's important to think about the age of the patient. If it's a kid, I will think different if it's an adult. And well, also the geographic place where the patient is, because it also makes me think about different things. I don't know, it's a pretty broad thing, so it could be almost anything.
I totally agree. Great thoughts. Ana, what else are you thinking just hearing those two symptoms?
Yeah, so when I hear fever, I always think like infections or tumors, and also lupus and some other collagen diseases. So with abdominal pain, I think we also have two things, that maybe some process that's causing, I mean, like that can cause, we have to ask like dysphagia, we have to ask about like where exactly does it hurt? Does it get better when you eat? Does it get worse? And some things like that.
Beautiful. What a fantastic start from both of you. Samuel, I particularly liked that you are already thinking about how important the time course will be to dissect each of those symptoms. A fever of just a few days versus a fever of 3 months is going to be a very different set of diagnoses, and same thing for the abdominal pain. So the chronology will be such an important part of the history that Franco gives us. And then Ana, I really like the way you're thinking already that abdominal pain is it's so vague, right? In fact, as I'll talk about in a minute, it can be something in the abdomen, but it can be from something outside of the abdomen. So it really is not too localizing for us. So you're already thinking ahead about what additional history questions are going to be critical for us to identify, where is this pain coming from? You mentioned difficulty swallowing. That will help us identify it perhaps to the esophagus or the chest in general. I think that sort of already making hypotheses about what could be going on and what questions we need is really fantastic. I'll just emphasize what both of you said is that this is very broad already, right? The fever schema that we get to practice a lot in Clinical Problem Solvers talks about the inflammatory causes that Samuel mentioned, specifically including infection, malignancy, autoimmune or inflammatory conditions, and then also effects of drugs or endocrinopathies can lead to fever and temperature elevation. And then abdominal pain, we start first thinking about the abdominal organs, and there's different schemas that we can take for that. Many choose the anatomic approach of asking or finding out if it's epigastric, right upper quadrant, right lower quadrant, etc., as a way to begin. And then also sort of thinking about some of the more common causes of abdominal pain outside of the abdomen. So thinking about thoracic diagnoses like a right lower lobe pneumonia or a pleural effusion that could cause some abdominal discomfort. Thinking about how heart failure can cause abdominal discomfort through a bunch of different mechanisms, including liver congestion, including gut edema, how pelvic organs can cause abdominal pain, both in men and women, and the urinary system, the certain kidney stones, pyelonephritis. We often think of flank or back pain, but can cause abdominal pain. And then finally, even outside of the organs, there's systemic conditions that can cause abdominal pain, like hypercalcemia, adrenal insufficiency, other rare diagnoses like porphyria. So abdominal pain, it's tough because it's really nonspecific, as is the fever. So we'll look forward now. Franco, if you want to go ahead and start giving us some more information, we'll see if we can piece this all together.
Yeah, great. So I can, before giving the HPI, I have to say that the setting of this patient is the outpatient first, and then the patient has a lot of previous medical history. So I think I will focus on that. So first, this is a 60-year-old male who presented to the outpatient setting because he was being followed by due to UTI of E. coli. He was on meropenem. But he also had 3 months prior a salmonella bacteremia plus a D11 and D12 spondylolisthesis. He also has an active Crohn's disease, currently on steroids, and an avascular history of an avascular necrosis of the head of the left femur. So he presented to the outpatient setting to follow up for the UTI, but he said that 1 week prior to this recent visit, he started to have fever again, despite meropenem. And something else that he pointed out is that he developed an acute onset diffuse mild abdominal pain 3 days prior to this visit, while he was doing physiotherapy. There were no nausea, no vomiting. Regarding the other previous medical history, everything was kind of stable because of the spondylolisthesis, no new symptoms, no new neurological symptoms over there. Meds, he's still on prednisone. He is still on meropenem, no family history, and social history, he's a big smoker. No biologics.
Whew, okay, got a lot more complicated early. Anna, before I have you jump in, Franco, do you mind if I ask a few clarifying questions, just because Samuel pointed out to us how important time course is. First, how recently were each of these other diagnoses discovered or managed? So the UTI for which he's on meropenem, how recently before this was that diagnosed?
Yeah, the UTI was, he was on his day 10 of meropenem. The salmonella bacteremia plus the spondylolisthesis was 3 months prior. The Crohn's disease was first diagnosed 5 years ago, but he wasn't on biologics. He was always on steroids because of insurance issues. And the vascular necrosis of the head of the left femur was one year prior.
And then to clarify, did you say, was it T11 and T12 spondylar? I just wanted to make sure we have that other diagnosis right.
D11 and D12.
And what was the actual pathology?
A spondylolisthesis due to salmonella, like an abscess. There.
Okay. So that's the salmonella bacteremia led to spine infection. But that is treated and all done with as far as we know. Okay. Okay, so now that we've got sort of the chronicity of some of those other medical conditions, my only other question before I turn it over to Ana, Franco, is, so now you're saying I know you mentioned the abdominal pain that's diffuse has just been the last 3 days. Is that correct? And then the fevers, what was the time course for the new fevers?
1 week.
Perfect. Okay, so now we're dealing with a week of fever, 3 days of abdominal pain on a background of months before salmonella bacteremia with spine infection, 10 days before UTI and meropenem, and then years of Crohn's on steroids. Thank you so much. Okay, Ana, we'll turn it over to you for your thoughts.
Okay, so right now I'm really thinking about infection. Like if he had the salmonella and also the UTI, we cannot miss that. And because of that, and also because he's on prednisone, we should always think about TB also. So we know that TB can cause extrapulmonar diseases, and one of the common manifestations could be abdominal pain. And also this fever. How is the fever like? Is it high fever? Is it everyday fever?
Yeah, daily fever.
Yeah, so a daily fever, like a stable daily fever, even though if he didn't have abdominal pain, we would already think about TB. So I'm really thinking about infection here.
Beautiful, Ana. What do you want to build onto that, someone?
Well, mostly emphasize that, well, he has been on Crohn like for a long time. He has been on steroids for a long time, so it conditions you to either cellular and humoral immunocompromise. So it makes you a lot more prone to infections. So I think the case is going towards infections, also because of the multi-drug resistance. He's with meropenem for 10 days. That's a super bacteria. So you have to be very careful and be worried, because what are you going to do? At least in the hospitals where I have been, that's the top we have. We don't have anything else on more than meropenem. So it's something to be very worried, to call infectologists to be really careful and think a lot about it. So the Salmonella septicemia and the E. coli, well, they were talking about both of them are encapsulated organisms. So we have to think if the Crohn have something to have with those things. Also Crohn's makes possible to have a fistula, an abscess. We'll need imaging to discard those things. Maybe I'll look for a foci of the infection. And well, maybe we'll have to see the urinalysis, how it's going, the E. coli, maybe seeing the labs. I'm just going to see the labs, because it could be also something on top of that. Maybe because of the immunocompromised state, you could have fungal infection, viral infection, something different. So it could be a lot of things.
Beautiful. Really, my thinking is aligning exactly with both of you. And what I'm hearing as the major concern is two things. One is we're still worried about infection first and foremost for two main reasons. One is still a relatively acute onset of fever, right? About a week. This is the acuity of the fever makes us worry most about infection right now. But then he has a very complicated history of infections in the past and ongoing immune suppression, as you cited, Samuel, with the steroids. So both the time course and who this host is make us really prioritize infection. The second theme you're both speaking about, though, is, well, how can someone get a bad infection when they're on meropenem? And so it really makes us think through what is the reason infection can be ongoing when someone is already on a very broad antibacterial medication. And you together captured the main reasons. One is it could be a non-bacterial source infection. And both of you cited that this patient could be at risk for mycobacterial disease, fungal disease, viral disease. Completely true. The imipenem wouldn't fix any of those at all. So reason number one to have a fever on a broad spectrum antibiotic is non-bacterial infection. Reason number two could be maybe it's a type of infection that isn't going to be fixed with antibiotics alone, like an abscess, right? Like an infection that actually needs to be opened up and cleaned out. And I think that's very important to consider, both abdominal abscess, given his Crohn's history. And then with this history of spine infection, we need to worry perhaps about if that was completely treated or not, or if there could be evolving infection in the spinal area and epidural abscess, again, which not necessarily would be treated with antibiotics alone. The third reason, besides non-bacterial infection or lack of source control, could be a resistance. And Samuel, same for us. The carbapenems are some of the most broad antibiotics we have in our hospitals. It is possible to get carbapenem resistant organisms, and that's very scary because there aren't a lot of medications that can help treat the infection beyond that. But resistance is the third category. And then the fourth category is, even though we're worried about fever for the reasons we discussed, we need to make sure once we've worked up for causes of infection, we're not missing a non-infectious source. So I think as we go forward, thinking about non-bacterial, resistant infections, abscesses, and other causes of fever are going to be important things. So let me ask you this, going forward, given how complicated this man is and how broad our differential is still, on physical exam, based on the hypotheses you have, what do you really want to make sure we examine him for?
Well, I think that we need to look like if there are any, like if his liver is enlarged, splenic, I don't know the word, I'm sorry. So if we have like some splenic, like, I don't know, so splenic, and also if he has a mass in the intestine, something like, I really, it's very important to put our hands and really make sure that we are making a good exam. If he feels pain, especially at some specific place, or does it hurt everywhere? How is this pain? Does it hurt when I compress? Does it hurt when I let my hand go? Some things like that.
Beautiful, very detailed abdominal exam, looking for peritoneal signs. I love that. Samuel, anything else in particular you want to really examine him for?
Well, I would love to see what you said about the columnar involvement of the salmonella. I would see if there are some tenderness, if there are neurological findings. I would love to see also if there is tenderness either in the kidneys or in the peritoneum. The more worrying things in the chat, they were saying about the arthritis and all of those things. So maybe focus into the most acute things that could, that could affect more the life of the patient, so we don't run out of time. Maybe that, but it's very broad anyway. Yeah,
great points. Good abdominal exam, good back and neurologic exam. Just, we didn't hear about back pain, which would, when someone has an epidural abscess, the first symptom they have is pain. The neurologic signs come late, but we'll want to make sure his back is okay. I completely agree. We want to make sure he doesn't have costovertebral angle tenderness. I would maybe even consider a prostate exam on him, because a complication of a UTI could be a prostatic abscess if the prostate was involved, and that might not be treated with antibiotics. And then you make a great point. Salmonella has a tendency to lead to vascular infection, and we need to be aware we may not be able to tell that on our exam, right? So sort of probably regardless of what we find on an exam, it's likely we're going to need some very detailed imaging to really check out parts of the body that we can't really tell just by laying our hands on the patient might be involved by the infection, like the aorta, as you said, given the salmonella history. All right, Franco, give us the exam.
Great. So for the vitals, the temperature was 38 Celsius. The heart rate was 120. Blood pressure of 130/70. Respiratory rate of 18. SpO2 of 98 on room air. He didn't look ill. Regarding the HENT, no lymphadenopathy, anything. It was pretty unremarkable there. Cardiovascular, tachycardic, regular rate rhythm, no heart murmurs, gallops. Pulmonary lungs were clear to auscultation bilaterally. There were no costovertebral tenderness. Regarding the abdominal exam, it was a pretty distended abdomen with tenderness along all the left side, no guarding, no rebound, no masses, no organomegaly. The bowel sounds were present, and to auscultation of the abdomen, it was kind of limited because of the tenderness. So it wasn't a true, just take that in consideration. Neurologically, pretty much unremarkable, no back pain. He was a little bit deconditionated due to the spine abscess, but there were no new neurological findings. The skin also unremarkable.
Thanks, Franco. Samuel, do you want to start first this time?
Also, it's a pretty difficult thing, but they will just focusing in the vitals. Maybe it's, well, there we have fever. They will have some tachycardia, but it could be in relation with the fever. Also, the pressure, the BP is a little high, but he also has 60 years old. And well, we don't know if he had previously diagnosed hypertension or something like that. We have to be sure that we know about that. And the saturation is okay. So I don't know, and say that it's an inflammation. There is inflammation. There is something that is causing all of these. And well, I don't know if I discuss the exam or I'll leave to Anna. It's okay. I don't know.
Yeah, well, I don't have much to say, but I think like I was really expecting like a mass or maybe a megaly, something like that, but we don't have. So I don't think we have like, I don't think the problem is at the liver. I think that we probably have something going on in the intestine. Or I actually have a question. In the physical exam, did you guys like examine his kidneys? Or
Oh, there were no tenderness to percussion.
okay, so I think the kidneys, they are probably not in the story here. So maybe something in the intestine or even in like in the cavity itself, in the peritoneum. And I don't know, on the left side, maybe like the colon, maybe some infection there, an abscess there. I don't know.
Yeah, Anna, I think it still could be a lot of things, but I'm with you that I think we can start honing in more on the abdomen, right? We talked about this could be in his spine, it could be outside his abdomen, right? Just the whole syndrome was so nonspecific, but the distension and pain on the exam, I think, should make us worry about something in the abdominal cavity. That could include still the urinary system, even with the normal exam like you asked about. So I don't have too much to add here. I guess I just want to clarify, Franco, the distension on exam, could you tell by percussion, for example, if it was air in the bowels or if there was fluid in there, or maybe it was difficult to tell?
It was kind of difficult to tell because of the pain, but no fluid, no.
Okay. Let's keep going forward here and get some more data.
I want to ask something. Well, just because he has Crohn's and everything, I don't know if the examination of the annus there was like a fistula or something like that, protuberance,
Normal.
something.
No, it was okay.
Great question, Samuel. Thank you.
Yeah.
All right, Franco, give us some more info.
Great. So labs. Regarding the hemogram, the hemoglobin was 8.3. The crit was 24. Leukocytes 15,400. Neutrophilia of 14,000. Toxic granulations were present. Platelets were on 400,000. Sorry. The CRP was on 31. Creatinine of 0.44. BUN of 17. The electrolytes were normal. Urinalysis, no, within normal limits, no leukocytes over there. HIV negative, hepatitis negative. I think I can stop there.
Anna, are you pushed in any direction by the labs?
Oh, I'm thinking if he's bleeding somewhere. So his hemoglobin is a little low. And I don't know, maybe he's bleeding probably in his feces or in the cavity. I don't know. So he also has a high white blood count, and that talks more in the direction of infection, but with his hemoglobin, I don't know right now.
Yeah, that's maybe a lab we weren't thinking about. I think we're probably not too surprised the white blood cell count is high, right? We're not too surprised the CRP is high. Samuel, any thoughts on the hemoglobin?
On the hemoglobin, well, he has been in Crohn's. He had Crohn's for a long time. Also, he has been in steroids, so we may think about anemia of the chronic disease. Because he has predominantly neutrophilic leukocytosis, we are like more confident that it's a bacterial thing. So it also brings to my mind the discussion about the carbapenem, the meropenem. So, and the neutrophilia, you have to be very worried about that. And also the urinalysis being normal, it somewhat like calms me, because I was thinking about a pyelonephrosis or something like that, but being the urinalysis normal, I think it's more like an abdominal basis. I am thinking that maybe it's an abscess or a fistula or something in the peritoneum. That's what I think in the left side. And because of the immunosuppression, the corticoids and the antibiotics doesn't have such a bright presentation. But we just have to see the imagings to be sure about that.
Yeah, I agree. And what kind of imaging do you guys want? If you had to order in the computer with your radiology department, what would be most helpful now?
I think I would order a CT, maybe.
And would you want it, Samuel, any thoughts on getting it with contrast, oral or intravenous?
Either intravenous and oral contrast and an enema to be everything there.
Yeah, I think for many, we want to see the vasculature well, right? We talked about how this organism he had before, Salmonella, can cause endovascular infection. We want to be able to see abscesses. We want to be able to see the outline of the gut well if there's inflammation, either from a new infection or as Crohn's. So I think we do want to get this with oral and IV contrast. I don't have too much else to say on the labs. I think, right, we're seeing signs of inflammation. I think the hemoglobin will have to interpret in context of what it has been in the past. But Anna, I think you're very right for us to make sure we don't miss blood loss as a cause. Though I do agree with Samuel that hypoproliferation from chronic inflammation certainly has to be part of the picture in him. And Franco, I don't know if you guys worked up the anemia more with iron studies, et cetera, but I think those are important categories. Hemolysis doesn't seem to fit, but we would have to put that on the list to complete the workup for that lab. But so far, to me, the labs don't give us too much more information. It does perhaps make an ongoing untreated GU infection lower on the list with the lack of the pyuria and the UA, but we really need a CT. I agree. Franco, if you want to go ahead.
I have only one question because Franco said it was an outpatient case. So do we make it an inpatient or do we keep...
Ooh, that's a great question. What do you guys think? He's in your office. What do you do? I see you're nodding. Are you saying, yes, we probably need him in the hospital?
I would put him at the hospital, but...
I would too. To me, above all, the heart rate of 120 with the fever. Yeah, maybe it is just because he has a fever right now and it's going to go away. But for a person who's on chronic steroids, who might have a stress state, adrenal insufficiency, who has a complicated infection history, who are going to need a lot of tests and quickly, I think it's going to be safer to manage him in the hospital. But I don't know, Franco, at this point, was he triaged out of the clinic elsewhere?
Yeah, we send it to the hospital.
Yeah. Okay, tell us what you have next.
Okay, so for clarifying, we weren't too worried about the hemoglobin because his normal values were around 9, 8, 7, sort of. So we did send him to the hospital, actually the emergency department, to get a CT because we were mainly concerned about abdominal collections and abdominal abscess there. So we did, in fact, this aliquot reveals the diagnosis, right? So we did find some.
Wait, can we make some? So you're going to say the CT is going to tell us the diagnosis?
Yeah.
Okay, let's sort of predict, Anna and Samuel. We've had some general ideas, but where could the diagnosis be on the CAT scan? And then we'll see what Franco tells us.
Go, Samuel.
What did you say?
I asked Samuel to go first.
Oh, okay, cool.
Yeah, I think we will find maybe a perforation or something, but it's not that cute. It's not that bad, and so maybe not. Maybe more that I think we will find a collection. We'll find a collection there, maybe with some air, because of the bacteria that is found normally in the intestine. Also, I don't know, I'm worried because it could be even a megacolon or something like that with C. difficile because of the broad antibiotics that he has been in a long time. So I don't know, it's difficult, but I think it would be towards a collection that we will find there.
Yeah, I'm with you guys. I think I'm most worried about an in the peritoneum around the gut, a foci of infection, probably from the intestines, just given the exam and the pain. I think we need to be careful about not missing a sequelae of this prior salmonella infection, right? Salmonella, we didn't talk too much about that bacteremia as a diagnosis, but it is known to kind of infect areas outside of the intestine, even though it's usually of gut origin. It can affect really anywhere, including the joints. We talked about the endovascular infection, but given the physical exam and the many other reasons this gentleman could have a GI source, I'm with you guys. I'm worried about something in the peritoneum above all. But Franco, tell us what you guys found.
Yeah, great. So we did find multiple collections, predominantly on the left retroperitoneum. So there were retroperitoneal collections, but what we did find and kind of didn't expect was that the patient had a huge infrarenal aorta and left iliac mycotic aneurysms, like really huge. So we didn't detect that on the physical examination. There were no kind of, because the auscultation was difficult, we missed that. And we also missed the fact that pretty much reviewing the history afterwards, like 3 years before everything happened, he got an ultrasound and there was a left iliac small aneurysm back then. So he was with the salmonella infection, he was on steroid, he was a smoker, he was doing physiotherapy while he developed the pain. And then we have the source of our infection.
And so Samuel and Anna, what do you guys think? What organisms are causing this? Is it one? Is it multiple? How do we explain both the infected aneurysms as well as the fluid collections? We thought it was going to be intraperitoneal, right? But actually it's retroperitoneal. Any thoughts of how we can put this together with his past history?
Well, I believe we have multiple microorganisms causing it. I don't think we can attribute it only to maybe the salmonella. Maybe it probably started with one bacteria, and then we have some other bacteria there now. And I don't know, maybe we have the salmonella, E. coli, and other ones from intestine and everywhere. So I wasn't expecting the aneurysm, but someone said that salmonella can cause. So I don't know if it's closely related or it's just a coincidence. And that's it.
Beautiful thinking. Samuel, any other thoughts on kind of what is actually causing these?
Yeah, I agree with Anna, and also it's very interesting that it's not intraperitoneal because Crohn tends to produce collections, abscesses, and fistulas, but in the peritoneum, it's not that common to see them in the retroperitoneum. So it was like interesting, but I think all of them are due to the aneurysm. Maybe yes, a salmonella infection, or maybe had something previously, and then the salmonella just start growing there.
Yeah, I'm with you. I think the infection of the aneurysm, right, with an organism that we said does this is a big concern there. It usually is the aorta below the renal arteries that is most commonly affected when people have endovascular infection with salmonella. And it's usually in an older person who doesn't have normal arteries to begin with. And Franco's saying, oh, we looked and he actually did have an aneurysm there in the past. That is the perfect setup for infection. It's usually the larger arteries that are diseased to begin with that get super infected. I still think the retroperitoneal fluid collection, that could still be the Crohn's with just fluid leakage sort of at back, posterior kind of in the abdominal cavity, as opposed to in the peritoneum. So Anna, I'm with you. I think we need to worry about polymicrobial infection right now. But really making sure we narrow in on worrying about salmonella for the aortic infection specifically. But Franco, let's turn it over to you for what you guys did and how the patient ended up doing.
Well, it was really a difficult case because he was on steroids. We need to get some source control there. So we consulted vascular, and they end up doing a femoral to supraortic bypass. So the patient doesn't have any infrarenal aorta anymore. Also, the kidney was so surrounded of abscess that he had to get a nephrectomy of the kidney. The Crohn disease, because of the insurance, we couldn't get him with biologicals before, so we kind of waited for starting the steroids. But eventually he improved his insurance. We started on antibiotics, and right now he's okay. So for me, it was like an amazing case for him to be able to support that surgery. The team was also amazing. So for me, it was like an amazing case. And I actually met this patient during a night shift with the CT for the first time there. So I was the first physician to look for the CT with the radiologists, and it was such a case. Hopefully it ended well. Wow,
how amazing that he ended up doing okay, including getting insurance access to medications for this. This could have gone very badly for him, so he was lucky to have you guys caring for him and have a positive outcome. And so just to clarify, Franco, the retroperitoneal fluid collection, was it thought that was a complication of pyelonephritis or from a Crohn's perforation?
No, it was due to the pyelonephritis,
From pyelo.
because the Crohn wasn't too active at that time.
And do you know, did they confirm on pathology when they took out some of the diseased vessel salmonella infection in the aneurysm?
Yeah, it was a salmonella infection.
Wow. So multiple infections in this gentleman on chronic steroids with a complicated kind of perirenal retroperitoneal abscess and salmonella aortic infection. Wow. Thank you for sharing that. Samuel and Anna, fantastic job. I can't believe that was both of your first times thinking through this. I wondered if each of you guys wanted to just share a reflection on the process, and then we'll turn it over to Vale for some teaching points.
Well, I wanted to thank you also. I was really nervous because I don't know, I've never done this before. And sometimes I was like looking at the whiteboard and my mind was just, oh my God, I don't know. But I think it was awesome. I really enjoyed it. And it was a wonderful experience.
Congratulations, Anna. You did fantastically. Hope you're here more and more and do it again and again. You did such a great job. Thank you. Samuel, how did it feel?
Oh, so thank you so much, because I was really nervous. Well, in fact, I am really sweating all my hands and everything because it's my first time doing this, and also, well, in English, because I'm not fully proficient in this. But it was pretty fun, and it was pretty interesting case. I'm pretty interested in going with you and the thought process and everything. I just love it, and I would love to do it again. And thank you so much for facilitating. Yeah.
Thank you guys. And I'll say I'm always sweating doing these. And we get to do this every week. It's a lot of fun, but I think that's one of the benefits is actually like sweating through and worrying. It's just going to make us better, right? The same way like Anna trains for her rock climbing in real life. This is training for our real life cases. So I think the sweating all of us do both physically and mentally is a very good thing. Franco, any final thoughts from you before we turn it over to Vale?
Yeah, actually, I just pull over an image of the initial CT if you want to see.
Yeah, we'd love to. Thank you.
I don't know if I can share my screen, or should I pass the image to the host?
Let me see if I can quickly make you co-host. Then you should be able to do it. Okay. Try now.
So there you have it.
Oh, wow. That is huge.
Yep.
Wow. I can imagine you're sweating, admitting him overnight, seeing the CAT scan, being like, oh gosh, what do I do?
Indeed.
Very impressive. Thank you. All right, Vale, we'll turn it over to you for some teaching summary.
Thank you so much for this case. That's amazing. And congratulations to both Samuel and Anna for an amazing discussion. I can't believe it's your first time. And so the chief concern was abdominal pain and fever. And Samuel reminded us of the characteristics of abdominal pain that we should keep in mind. And we can remember them with mnemonic Socrates, which includes site, onset characteristics, radiation, associated symptoms and signs, timing, exacerbating and alleviating factors, and severity. And as Ravi always mentions, we should never forget that most causes of abdominal pain will require imaging, because the exam can sometimes be not impressive, as in this case, but very revealing. And also, Steph reminded us of the extra-abdominal causes of abdominal pain that could, because of irradiation, be mistaken as an abdominal etiology, such as pneumonia, pleural effusion, and gynecological and genitourinary causes. And then we were reminded also of emerging negative causes of abdominal pain, such as porphyria, adrenal insufficiency, and hyperkalemia, and others electrolyte and metabolite disturbances. And then we went through the Venn diagram of fever and abdominal pain. We should think about inflammation, as Anna mentioned, and the mnemonic IMADE is a reminder of that, but also tempo is queen. And so in a case of acute abdominal pain, we should prioritize inflammatory causes such as the itis of the abdomen, and in a more chronic and subacute pain, other etiologies such as malignancy or maybe an autoimmune etiology. And with the factors of this patient, such as the fact that it was an immunocompromised patient, definitely prioritize infections of the immunocompromised. And then, well, the patient had a course of antibiotic failure with meropenem. And so antibiotic failure can be divided or discussed in three categories: a mistake in diagnosis, when there's a wrong bug diagnosed, and so the wrong drug is given; then a non-infectious etiology that will not need antibiotics; and then the second category is a treatment failure. And so maybe a low doses, the patient is not taking the medication, or a failure on the spectrum of medication, or there's no source control. And then other possibilities such as resistance, which is scary, and then the natural history of the bug, which could be, for example, MRSA or broad spectrum bugs that are resistant inherently to antibiotics. And then in the chat, I believe was Kirsten that shared this great pearl of abdominal tenderness of pain out of proportion to exam findings. And so in this patient, the exam was not very revealing, but the pain that he referred was really intense. And so in this category, we can include mesenteric angina, mesenteric venous thrombosis, colitis, and other series such as zosters or neuritis or a neuropathy. And then with the past medical history of Crohn's disease, the risk of megacolon perforation increases, and also the bugs that could be compromising this patient because he's immunosuppressed because of the use of steroids include entamoeba, ascaris, histoplasma, cytomegalovirus, chagas, typhlitis, Kaposi sarcoma, and microsporidia. And then the patient also had a history of Salmonella septicemia, and it was a final diagnosis that it was an infectious agent. And so this bug can present usually with gastroenteritis, but can also include presentations of bacteremia and endovascular involvement, especially in immunocompromised patients, such as a patient that uses steroids or has HIV, but also in patients that have sickle cell anemia. And the aneurysm, consequence of a salmonella infection or endovascular compromise, can affect both large vessels and small vessels. And the risk include arterial surgery in the past medical history and intracranial hemorrhage. And so thank you so much, everyone, for an amazing case and discussion. Hope to see you tomorrow.
Thanks, everyone. Have a great day. Congrats again, Samuel and Anna. And Franco, thanks for an incredible case and some great teaching. Take care.
Thank you.
Bye.